Hello everyone. I thank the organizers and the moderators for giving me this opportunity to talk about how to build a pancreas. I'm dividing my presentation into two parts. The first talks about the Pancreatitis Center that manages acute and chronic pancreatitis patients and associated complications, as especially the pancreatic pain. The second part would be about a pancreas cyst clinic or a pancreas cancer screening center, which will be worked more closely in collaboration with the oncologists and the surgeons. Starting with Pancreatitis Center, what is it? Pancreatitis Center is a multidisciplinary clinic that was started in 2007 by Dr. Vikesh Singh with support from Dr. Anthony Kalu, then Chief of the Division, and is dedicated to advancing the care of patients with inflammatory disorders of the pancreas through clinical care, research, and education. Pancreatitis Center offers a full range of services available to evaluate and treat pancreatitis. For example, we offer genetic testing that is specific to evaluate patients with pancreatitis. We offer endoscopy of different kinds to evaluate and treat patients with pancreatitis. We offer ESWL or extracorporeal shock wave lithotripsy to treat patients with pancreatic duct stones. We work closely with the pancreas surgeons and also offer biologic infusions for patients with autoimmune pancreatitis, and we also offer dedicated pain management for patients with pancreatitis. And we have a sub program for total pancreatectomy with islet cell autotransplant. Before I go into the different components of Pancreatitis Center, I want to mention some noted recent accomplishments of our Pancreatitis Center. Our Pancreatitis Center was designated by the National Pancreas Foundation as a Pancreatitis Center of Excellence, which is reserved only to a few centers which meet all the requirements. Our TPIIT program is the only program in the United States to offer minimally invasive procedures, that is through laparoscopic and robotic surgery. We have the largest experience to date in the United States with pain phenotyping in chronic pancreatitis using quantitative sensory testing, which I will talk in more detail in the next few slides. We have increasing experience with neuromodulators for treating pain in patients with gut-brain axis disorders, and we have established a dedicated medical pancreatology fellowship, one of the few in the country. We have gastroenterologists manage ESWL equipment, and new programs in pancreatitis at other academic centers have been modeled after us, such as at Columbia and Emory. Now going on to what are the different components of Pancreatitis Center? This schema gives us some overview of the different participants in the Pancreatitis Center. We obviously have gastroenterologists or pancreatologists who lead the Pancreatitis Center with support of nurse practitioners, nurses, and medical office coordinators. We also have dedicated pancreas surgeons, dedicated pancreas radiologists, endocrinologists, rheumatologists, and pain management specialists or a psychiatrist. We also often require support from geneticists, nutritionists, and lipid disorder specialists in certain situations. When you think of Pancreatitis Center, always try to think beyond gastroenterology. Like we would need a dedicated surgeon with expertise in managing pancreatic disorders, and we often have combined clinical sessions with the surgeon where we see the patients together, especially for the patients who require pancreatic surgery and especially the TPIIT surgery. And these are the surgeons with expertise in minimally invasive pancreas surgery, where they do these surgeries by laparoscopic and robotic approaches. And we work very closely with radiologists with expertise in abdominal imaging, or especially of the pancreas. And we have weekly dedicated pancreatitis center case conferences where we review our patients together and often also talk about research. We work closely with endocrinologists experienced in the management of type 3C diabetes, which is seen in chronic pancreatitis, which is often more challenging to manage compared to the typical type 1 or type 2 diabetes. So we would need some dedicated endocrinologists. And these are the same endocrinologists that also work closely in evaluating patients and managing patients with TPIIT. We work also with rheumatologists, especially for the management of autoimmune pancreatitis, who require rituximab, and similarly the case for IgG4-RD, IgG4 related disorders. Now to talk about the pain management at the Pancreatitis Center, we know that majority of the patients with chronic pancreatitis have chronic abdominal pain. And traditionally, these patients were managed with opioid analgesics or with ERCP procedures. But with our newer understanding of the pathophysiology of the pain in these patients, we understand that there is an important role of the nerves or neuropathy or nerve sensitization in these patients that contribute to their pain. So we have been adopting newer techniques to evaluate and manage these patients. For example, we have been doing pancreatic quantitative sensory testing or PQST to test the phenotype of these patients with pancreatic pain to understand how much of their pain is from neuropathy. And by understanding these phenotypes of these patients, we have been utilizing neuromodulators that helped us limit the use of opioid analgesics, endoscopy procedures, and surgeries. So we work closely with neuromodulator specialists in psychiatry to co-manage these patients. We know that 40 to 60% of patients with chronic pancreatitis have calcifications in the pancreas, and a good number of them have stones obstructing the pancreatic duct causing pain. And traditionally, these patients were managed by using ERCP procedures to break the stones in the pancreatic duct. But the stones in the pancreatic duct are very hard. These are calcium carbonate calcite based stones. So there is enough research to show that ESWL or extracorporeal shock wave lithotripsy makes the ERCP procedures easier when you break the stones or fragment the stone to some extent by using these non-invasive procedures before going for ERCP. And there has been some debate in this research studies about the efficacy of ESWL procedures because it very much depends on the protocol used to do this ESWL procedure. For example, with regards to the power of the shock waves or the number of shock waves used. And historically in the United States, mostly these were performed by urologists. We used to refer the patients to the urologist and they used to do the ESWL procedures for us. But the urologists use a very different protocol because they are so much more used to the urology based stones that are different from the pancreatic duct stones, and they use much lower power settings and much fewer number of shock waves. So we did not have as much good results when we used to send the patients to the urologist for ESWL. But now we have acquired our own ESWL equipment or we started renting it and we manage this ESWL procedures. We do them ourselves. And we have been doing this ESWL procedures in conjunction with ERCP, and by using this protocol, we have been able to reduce the number of invasive procedures and minimize the risk of complications. And there is enough research that to show that gastroenterologist managed ESWL has improved duct clearance when compared to urologist managed ESWL. Gastroenterology has become such an advanced specialization now that we have many fellowships beyond gastroenterology. Like we have therapeutic endoscopy, IBD, motility, neurogastroenterology, transplant hepatology, and so on. But medical pancreatology fellowship was not recognized as such previously. Pancreatology has now become a niche field requiring additional training and experience due to the complexities of pancreatic disorders and the nuances involved in their management. So we started a dedicated 1 year medical pancreatology fellowship in 2019. Though we have trained gastroenterology fellows in pancreatology before, this is a dedicated fellowship only for medical pancreatology. So the medical pancreatology fellows rotate through various pancreas centers like the Pancreatitis Center, Pancreas Center, and Pancreas Cancer Screening Center. They cover inpatient consults and have electives in abdominal radiology, pancreas pathology, pancreobiliary surgery, pancreas oncology, pain management, and psychiatry services. They also have an optional endoscopy experience that is customized to each candidate based on their level of experience, but the primary focus of this fellowship is on medical pancreatology alone. Now moving on to the second part of the discussion, which is on the Pancreas Cyst Clinic and the Pancreas Cancer Screening Centers that are led by Dr. Anne-Marie Lennon and Dr. Marcia Canto. So this is also a multidisciplinary center led by gastroenterologists or pancreatologists with support from nurse practitioner, nurses and medical office coordinator, and we work closely with surgeons, radiologists, pathologists, and oncologists here. The setup of the Pancreas Cyst and Pancreas Cancer Screening Centers is somewhat similar to the Pancreatitis Center, which is through a multidisciplinary approach. We work very closely with the surgeons who have dedicated expertise in pancreas surgery, and we have combined clinic sessions where we see the patients together. So we go see the patient first and then the surgeon sees, or the surgeon sees first the patient and then we go see the patient after. So it's a combined clinic that is very much beneficial in discussing the patient right away at the same time. And it's very helpful for the patient perspective also, seeing both the gastroenterologist and the surgeon at the same time. And as I mentioned before, these are surgeons with expertise in minimally invasive pancreas surgery through laparoscopic and robotic approach. And we work closely with radiologists and pathologists with dedicated experience in pancreas. And we have weekly pancreas cyst clinic case conference, which is also participated by oncologists and other specialists. These are some of the take-home points from our experiences. Pancreatology has become a niche field requiring dedicated center of excellence. We would recommend a multidisciplinary team-based approach, collaborating with surgeons, radiologists, pathologists, and other less conventional specialties such as endocrinology, rheumatology, and psychiatry, which would really improve the management of patients with pancreatic disorders. We would also recommend you to become early adopters of novel treatment approaches such as neuromodulators use, pancreatic quantitative sensory testing for pancreas pain management, and also recommend considering a gastroenterologist run ESWL. We also recommend you to consider having a medical pancreatology fellowship, which is an excellent way to build resources and also to train future pancreatologists. Thank you. I left a few minutes for questions, and I also left my email here for any further questions or discussion.